Thank you everyone for joining us today. Just again, a few little pieces of etiquette is please keep your video off. It will help us with bandwidth so that we can keep our Zoom connection going. And if you have any questions, I'm going to presume that some people have never used the Zoom chat before. And I'm just going to take you through how to do that. In your command bar, which is this black bar that shows up in your Zoom session, you will see chat. And if you open up your chat window, you can send a chat message to Karen Laforet, our speaker today. And just type in your chat to Karen or to me. I'm listed there as Tanya Sherry. And we will field questions to our presenter today, Karen Laforet. If there's a lot of questions, my apologies in advance for not getting to them immediately or even today. If there's something that we haven't answered, we'll try and answer post-webinar, but certainly we're going to try and get through as many questions as possible. Karen has allocated a good amount of time for some questions and thought and reflection based on your questions. Great. Now, if you are having problems with your audio, one option is to join us via telephone. And the phone number would have been sent or is on the bottom of your control panel. If you are unable, if you're having trouble with your audio, you can switch to phone audio and the system will give you a phone number. If you just select it, you click on your little up chevron and you'll see switch to phone audio and it should give you a phone number. If you are having technical difficulties and can't find the phone number, just text us in the chat line and we'll try and help you. And actually more people are coming in. So without further ado, I'm going to start by introducing our speaker today. Karen Laforet is a registered nurse and also Masters of Science with a rich and diverse working history in not only Canada, but also the United States and in Germany. She is a nurse leader with over 30 years of healthcare experience and expertise in critical care, community care, industry, and academia. Karen has proven skills in leadership, team building, clinical training and innovation, business development, marketing, and healthcare management. Karen has been teaching for us for the last 4 years, and we've certainly seen a lot of excellent feedback from Karen's teaching and mentoring of many of our students. She's currently the program lead for our IV Infusion courses. Karen is also a board member of the Canadian Vascular Access Association and member of the CVAA's Best Practice Guideline Development Group and a committee member for the College of Nurses of Ontario. She's also a member of the International Guideline Development Group for Wound Infection for the CNO and a member of Wounds Canada Policy and Advocacy Committee and a current past president of the Ontario Wound Care Interest Group. She's also the past president and founding board member for the Canadian Association of Critical Care Nurses, a former board member of the International Association of Vascular Access, and a member of the RNAO Best Practice Guideline Development Team. She sits on the editorial review board for the Infusion Nurses Society Journal, the Diabetic Foot Canada Journal, and the Journal of Vascular Access. So I'm really pleased to introduce you to Karen Laforet. Karen, can I throw it over to you?
Just adjust my screen here. Thank you very much. Okay. Welcome everyone. I am absolutely thrilled to have so many people interested in this topic. It is near and dear to all of our hearts as healthcare professionals. And really when we think about medication safety and reducing medication errors, it's something that we focus on every single day. However, with COVID-19, it really has become an even greater issue for us. I first want to say that my admiration and gratitude for the work that you're doing in every care setting cannot be overstated. It is, you're doing an amazing job, and I just thank you for what you're doing. The reason why we're here today is because of COVID-19. We now have a high-risk environment in every single care setting. We have risk of exposure, we have limited equipment and PPE. Our working conditions have changed, there are longer hours, we have reduced days off, and there's the constant threat of exposure, as I've already said. This is a scenario that makes a perfect storm for things going wrong. And, you know, and we don't want that to happen. And so, you know, as compassionate professionals, healthcare professionals, we want to do the right thing. And I'm going to give away my age by saying this. Way back when I was working in critical care when the AIDS crisis hit in the early 80s. And so it was similar yet different for now. We didn't know what was going on back then. Back then in the early 80s, we didn't have PPE at all. It wasn't standard. We were dealing with weird and crazy pathogens in the critical care units where I was working. Fear was rampant. And it was a time where we could have led by fear, or we could have collaborated. And I was amazed at the work and the willingness of everyone to band together to make sure that we were doing the right thing for our patients, as well as taking care of the nurses and the workers that were doing their jobs. Then, as now, healthcare professionals, and especially nurses, and I will say I'm biased, and I recognize that there are other healthcare professionals listening to this webinar, but I am biased because I'm a nurse. What can I say? Anyway, but we are, as a group, we are resilient, we're creative, we're tenacious, and those are all really, really good things. And so, because of that, we're here today. We only have time to scratch the surface of this particular issue. So I anticipate that there's going to be more questions than answers, but hopefully there'll be enough to generate critical thinking, which is absolutely part and parcel of what we do. And so for that, I really want to start with healthcare professionals, because medication safety isn't just around reducing medication errors, it's we are the ones that administer that medication. And so then therefore, how do we then take care of ourselves to do it? We know that nurses administer the medication. We're also responsible and accountable for what for ensuring the 8 to 14 or 16 rights of medication, depending upon which your organization aspires to. We know that physicians and nurses, nurse practitioners write the orders. We know that pharmacists are also critical to the success. We can not really do our jobs without them, because they can help us look at alternatives. For home care and long-term care, you may need to seek out different pharmacies depending upon what the need is, but nonetheless, let's not forget our pharmacist friends, because they are absolutely critical for us. The focus here will be on IV medications, because that is the highest risk and the most challenging. We know that working the long hours and being understaffed and not having the right equipment does impact our behaviors. What happens is that there is the risk of a behavioral drift, where we know what safety measures and protocols are in place. We're under the gun, and so how that shift is, well, maybe if I just make this little change here. And those things are going to happen. And so what I'm hoping to do today is really talk about the principles of medication safety and how those can be adapted to the environment that you're working in right now. And as I said, I want to start with healthcare professionals, because it is absolutely vital that we take care of ourselves, that you take care of yourself during and after your shift. I've mentioned the stressors already. But the thing is that what can we do, or what can you do in your environment to help support yourself and reduce those stressors? I know that there are some places where if they have enough staff, what they're doing is having shorter shifts, or extending the shifts, but then giving you more time off in between so that you get to rest. I have to stress this so much, because don't do as I do, do as I say, but taking a break is absolutely important. One place I worked, I was the only registered nurse in a surgical trauma unit. It was a 15-bed ICU, and we had LPNs, but I was the only registered nurse. And my only relief was the supervisor, the admin supervisor, who was floating throughout the hospital. And so she would come down and say, okay, I have 10 minutes, leave. And I'd go, yeah, but, and I'd go, no, leave. And so she was the best thing that ever happened to me, because I did. I took a break, went downstairs, went to the elevator, walked outside, came back in. It cleared my head. We are all aware that there's research that's telling us that we have to give ourselves a break. We have to give our eyes a rest from the computer. We have to give our brain a rest from having to concentrate. Otherwise, that's where we make mistakes. Think about working as a team. I know that if you're in home care, that might be a little challenge because you're independent. In long-term care, you may be the only registered nurse or RPN that's working there. However, grab another set of eyes. At one point where when I was working in home care, and it's a bit different, but we were just starting to use negative pressure wound therapy, VAC therapy. Very different, quite complex. We were like, oh my gosh, how are we going to do this? We didn't have FaceTime like we do now, but we had the phones, and so we worked together to have somebody on a call with us. So if we ran into any problems or had questions, we had somebody that we could rely on or touch base with. In home care, use your family, use your patient, use your family member. Did this a lot when we were teaching patients how to give their own TPN at home. Using them, so working as a team so that you're not carrying that load yourself. Make sure you have proper lighting. I know it sounds kind of odd, but we do. Like, we want to balance the need for us to be able to see what we're doing, at the same time making sure that patients sleep. If the lights are too dim, then there's a risk of misreading a medication. There's a risk of misidentification, not being able to regulate the pumps properly. So lighting sounds kind of like a no-brainer, but it's something that we always have to remind ourselves of, that we have to do this. Reducing distractions is a real challenge. And again, probably most of you have seen those pictures of a bazillion pumps and the computer and the nursing station all in the hallway, and people working side by each trying to get all this work done. It's very difficult to do that. I've worked in a number of critical care units where they were open units as opposed to private rooms. And so one of the things that we did was we established what we called the red zone. So we had areas of red tape, that once you entered into the red tape, the nurse at the patient bedside was the one that told you that you could speak or not. So like, they basically claimed ownership of that little area so that they would help to reduce distractions. One other place I worked is that we had laminated cards that we would clip onto the either foot of the bed or on the curtain, so that people would know that this is a new do not disturb sign, and to enter cautiously, so, again, to reduce distractions. It may not be ideal where you could actually have actual quiet that's required for admixing medications or doing calculations, but trying to reduce that distraction, even by having a little zone, might be something that would be beneficial for you. And so for those of you who are doing hallway care, how are you managing that traffic flow? How are you managing the distractions? If you can share some of your success stories, that would be really helpful for us. The other thing that's helpful for you as a healthcare professional is the standardization of certain tasks. When you're wearing PPE, communication is diffused, no pun intended actually, diffused. At the same time, it's difficult to hear somebody when you have a mask on. So standardizing how you will communicate and what will be communicated is going to be really helpful for everyone on the team to be able to hear what's going on. It reduces the stress of not knowing or miscommunicating. Make sure that everybody is on the same page. Do things like an old-fashioned checklist, doing written statements. One place that I can't remember who it was that recommended this to me, but they had those that they use for children who have difficulty speaking, where they have like an actual picture board, and then pointing to this to help to reduce the miscommunication that happens when you're wearing PPE. Try and standardize treatment times. And that's where you're coordinating everything together. So your assessment, the treatment, your medication administration, there are going to be medications that you will have to give at the patient bedside. And so coordinating all of those things together will help to reduce that stressor for you, reduces the risk of exposure. So coordinating those times will really help. There will be exceptions to that, of course, but however you can do that, it's really good. And again, trying to think about how can we do things differently. For example, is there a way that you can standardize the dosing dosages and also the times for medication. We've always done it this way. We have a routine that we normally follow. Given COVID-19, we may need to be looking at that differently. So the principle is to make sure the patient gets the right dose at the right time and the right amount. And so how can you do that in a way that helps to reduce your risk of exposure, utilize the current equipment that you have, and that includes your PPE, and also do the best for the patient. So those are some things that you might want to be thinking about. For home care, long-term care, it's really important to maximize resources and reduce your risk of exposure. These are other things. So think about, when we're thinking about standardizing medication administration for home care, is there a way that you can do this daily as opposed to having to go in maybe twice a day or 3 times a day? Is there a way that you can utilize virtual care, teach patients how to change their IV bags so that you don't have to go in? So this is something that virtual care has taken off like crazy. There's a lot of different options out there, and it's an option for you, especially in the home care environment, where you can reduce your risk of exposure and at the same time be a viable resource for your patients. So that's something that you can think about doing, and how can you best leverage the technology that's available. So let's talk more about medication administration, because that's the big thing that's on a lot of people's minds. As I mentioned, we've talked about the hallway care, so the pumps in the hallway. That's the big topic. What about the location? What about availability of pumps and administration sets, about equipment? And how do we maintain and do ongoing patient assessments to ensure that we're providing the best care possible? The pumps in the hallway are an interesting one. It is a temporary solution, and kudos to people that came up with that, because that's quite creative and innovative, an example of how we work every day in looking at creative solutions. Some of the things you want to remember is you need to ensure that you have the right dose. And what do I mean by that? If you have an extension set that's going like for 8 feet, all right, then you have to calculate in things like your priming rates. Like, how does that affect your extended tubing? The recommendation so far, the best practice is using microbore tubing. The ECRI, which is aligned with the Institute for Safe Medication Practices, they tested commonly used pumps and showed that by using an 8-foot extension set on your regular pumps, there's about a 5% accuracy between 5 to 300 mils per hour of infusion. And that 5% accuracy is actually what we are guaranteed, we are guaranteed when we're using infusion pumps. So that's good. The titration is going to be different, because you have to think about, there's going to be a delay going through 8 feet from the pump to the patient. So that you need to factor that titration and when that effect will take place based on the delay. Your pharmacist can help you calculate that out. Think about things like the volume of your manual flush. This is an absolutely critical consideration regardless of your setting. Not only during COVID-19, but ongoing. When you're doing an IV push medication, the rate of the flush must be the same rate as the IV push infusion. So if your IV push takes a minute to infuse, then your rate of your volume of flush would be 1 ml per minute. Otherwise, you're giving the patient a bolus. So you need to be thinking about that. So again, when you're looking at giving an IV push medication and then using the pump to flush the line, you need to be factoring in that rate in order to not bolus the patient. Okay. Some of the things that you have to remember, if you're keeping the vein open at about 5 mils per hour, or if you're titrating and you have a low volume, then there may be problems. You can have occlusion alarms simply because anything under than 5 mils has been tested that you will end up getting some challenges with how the rate will go. For greater than 300 mils, because you're using microbore tubing, it's a small diameter, and so therefore you're going to create a high back pressure, and then we'll also get an occlusion alarm. So those are things to think about. It might not work very well given what you're providing for the patient. One of the things that can happen is you can also have air alarms, and this will happen in any setting, regardless of the pump that you're using. When you have temperature changes in your in the infusate that you're using, so if you have medications that that require refrigeration, and then you hang them up, as that medication warms to room temperature, you will get off-gassing, which we refer to as like those lovely little champagne bubbles that happen in the tubing. You have enough of those, you will have air alarms. And so you have to factor that in as well, that if you can, again, depending upon how long the infusion is, have your medication out at room temperature before hanging it. Or you might have to modify how you infuse it in order to reduce that off-gassing and those microbubbles. The other thing about refrigerated medications is that how long are they stable for? So if you're hanging it, again, you're working with an 8-foot extension and you're infusing this over time, this might become a problem. So those are things that you have to factor in if you're extending the pumps away from the patient. The other thing that we need to factor in is the residual volume risk. There's research that's just been published in the Infusion Nursing Journal from Harding and all that have confirmed that up to 35% of medication is not administered due to residual volume in the tubing. That's quite a lot. So I know that there's been speculation in other documents that have said, estimating anywhere from 10 to 20%. And regardless, that's still a lot. So if you're looking at 20% of the medication that you're infusing is being trapped in the tubing, then we're underdosing the patient. For antibiotics, that could be, ineffective treatment. If you're looking at inotropes or any other medications, then you may not be seeing the same effect because they're actually underdosing. So the pharmacist and yourself need to determine the risk and recalculate your administration volume and dilution, as well as your priming volume, to make sure that you're reducing that residual volume. The other thing to think about, and I'll get back to, speaking back to IV direct or push medications, is that these should not be diluted. Okay. There's research by Denang and all that have shown that diluting, and also the Institute for Safe Medication Practice, are very clear that you should not be diluting ready to administer syringes, or an IV push medication. The challenge is that you may get underdosing, as I mentioned before, depending upon what's left in the tubing. You may get an indirect dose. You also may get an incorrect medication due to non-labeling. So it all increases the risk of a medication error. The other thing is that each time that we tamper with something that is ready to use, we increase the risk of contamination and then therefore causing a bloodstream infection for the patient. Okay, so speaking of bloodstream infections for the patient, I want to talk about just briefly with medication is the type of vascular access device that's going to be used. What they're recommending, and again, mostly this is for critical care, but if you are looking at using hallway pumps in the hallway, then really the patient should have a central venous access device. The preferred one is a PICC line, preferably in the upper arm, simply because of, first of all, access. Secondly, because the patients are being pronated and supined, so their position changing, there is less risk of it getting dislodged if it's otherwise, unless it's the chest, then there's a risk of the catheters being caught or dislodged. The other thing is that, again, with a peripheral vascular access device, you need to check it more frequently than you do with a central vascular access device, again, depending upon what you're infusing. If the reason why you've had the pumps in the hallway is because you want to reduce the risk of exposure, then a central line also provides better safety and also better administration consistency for the patient. Some other practical considerations, again, for hallway pumps, is your cleaning protocols will obviously need to be done in the hallway. If you're looking at some of the practices that are happening for being able to identify the pumps are for the right patient, is that some places are actually taping a patient ID bin right onto the pump. So again, from a privacy perspective, that needs to be removed. If you're looking at the tubing, the protection of the tubing, some people are wrapping it in a blue pad, or they're calling them chucks, whatever you call those, and then taping them to the floor. For a little bit more money, one of your options might be to get the tubing coverage or the cable coverage that is used in offices. It's a rubber mat. There's grooves underneath it that the cables actually lie into, and then you can secure it to the floor. This way the tubing isn't residing on the floor whatsoever. You can tape that down, use caution tape or something like this, so that you reduce the trip factor and you reduce the risk of not only the healthcare professionals tripping on it and injuring themselves, but also disconnecting. So that's probably a better option than blue pads on the floor. But you do want to make sure that your tubing isn't lying on the floor because it's quite dirty. You want to make sure that if there's any Y connectors or hubs, that those hubs are covered with a disinfection cap, because you want to make sure that those are clean because they are low on the floor. Okay. Make sure that you secure, I can't state this enough about securing any tubings. I come from a time when we had so many individual pumps and things that we used the pink tape. We used to call it hospital duct tape. We would use the pink tape because it stood out, and we would put that on the floor wherever the cables were to alert people that there was something there and to just be aware of. We couldn't use the red tape because that was our safety no distraction zone. So, but those are things to think about, like how do you standardize those practices so people are aware of what to look for when they enter a patient's room if the pumps are on the outside. You also might want to consider moving your patients closer to the door. There are a number of places that have done that if it's possible. So again, you reduce the length of the extension tubing that you need. And another very practical consideration is that, do you have enough power? Do you have, because again, are you going to be using extension cords in order to plug in all of the infusion pumps, which adds more cables and more risk for tripping and disconnection? So those are things that you have to be looking at. One thing I forgot about the extension sets, which is important, is that they're all luer locked. At the same time, though, you want to make sure that you might want to double back tape in order to make sure that those are really secure so they don't come apart quite any easier. Okay. And the last thing on the pumps in the hallway when using extended extension sets is that what medications can and cannot be used when you have a longer extension sets. We all know insulin is one that is a medication that gets absorbed into the tubing. It actually gets, the tubing absorbs it. It's a PVC tubing, and so therefore what you end up having is feeding insulin to the tubing as opposed to the patient. Pardon me. So that's one thing that you really want to be cautious of. You may not be able to administer insulin from the hallway into the patient's room. Again, consider an insulin pump. Consider some alternatives to an insulin infusion. What else can be done in order to provide the patient with a medication that provides better measure of safety for them? Okay. There is a real concern about shortages of administration sets because, again, the volume was not anticipated. So there is, if your practice is to be changing the tubing every 72 or 96 hours, there is research that has come out of Australia that has demonstrated that changing IV tubing every 7 days does not increase the risk of infection. Now, that is, the exception is there are certain medications that are what I like to affectionately call sticky. Things like your Cipro, so some of your antibiotics like Cipro, penicillin, those get really gungy, so those may not last the 7 days. But for a lot of your infusions, your inotropes, hydration, those kinds of things. They have shown that 7 days is a decent wear time. Wear time is acceptable and does not increase the infection risk. So that's something to consider during this time to, again, to be able to manage the volume of supplies that you currently have and to reduce the risk of running out. There is the risk also of pump shortages. So, and for home care and long-term care, this is where, depending upon the region that you're in, they're reallocating those pumps and moving them into the hospital because this is the critical area. And also on med-surg floors, they are moving those pumps into the critical care areas because that's where the need is. Make sure if you're in a hospital, there's a lot of different units that have infusion pumps. Okay, they might not be a smart pump, but they might have an infusion pump. So think about X-ray. Like all of your radiology areas may have them, research departments may have them, and so you might be able to look at getting those allocated to where they're needed. So what might happen, the risk is that if you're getting pumps reallocated and brought in from other sources, they may be different pumps. Of course, then the concern is that do you have the right sets for those? And do you have the adequate training so that you know how to use them? So a few things that you want to consider when you're looking at your policies is that if you do have to bring in other pumps, make sure that as much as possible, have the same pumps for the same unit. If that's not possible, same pumps for the same patient. Been in situations in critical care where we had an outbreak of a really rare Pseudomonas pneumonia when I was working in Florida, and we didn't have a lot of pumps, and so they brought some in, and so what we ended up doing is a lot of shifting, but we kept the same pumps with the same patients so that at least that one nurse was able to know how the pumps worked for everything, rather than having to, again, you're having to reset every time you use a different machine or device because you're not used to it. So that increases risk for error big time. So again, if you can keep them all in the same unit, same pump, same unit, that's great for safety. If that's not possible, same pumps for the same patient. Let's say you don't have any more pumps, and that's possible. So because I've been around a long time, I know what that's like. And some people in home care know as well that we're used to running gravity infusions. So, you know, good old-fashioned gravity does work. I mean, in long-term care, a lot of times that we use gravity infusions as well. It's important that you calculate your count by drops. If you're unable to get a flow rate, flow regulator like a dial-a-flow or something like that, you can you count by drops. We will add, as follow-up, we'll add the calculation for you. It's quite simple, but if you haven't done it for a long time or if you've never had to do it, we'll add that so that you can be reminded that that's always an option for you. The question that that we need to be asking as healthcare professionals, not only during COVID, but moving forward, is the IV actually necessary? Now, outside of critical care, that's the exception. So, I mean, it's a given that they're going to have that. When we are on med-surg floors, when we're in home care, we're in long-term care, does the patient need an IV? There is the standard, you know, it's just by default that patient will come to emerge, or patients in home care, the family doctor says, okay, I'll give you IV antibiotics, so IV ceftriaxone for 5 days. That's great, you don't have a pump. The question is, does the patient actually really need the IV? There are alternatives to IV medication. So let's say, let's use this as an example of an elderly patient in long-term care. First of all, you don't want them to be going to the hospital, right? But we have an elderly patient, recurring sepsis, secondary to UTI, urinary tract infection. They're severely dehydrated. The doctor says, you know what, they need IV hydration and they need IV antibiotics. And you're absolutely right. The reality is, if you have a person who's 85, who's severely dehydrated, are you going to find a vein? Probably not. And so What happens in a lot of scenarios is that the nurses try to find a vein and can't. Then they send them to emerge to try and find a vein. What about if we looked at it in a different way and said, okay, this patient needs hydration. Why don't we use hypodermoclysis, or also called subcutaneous infusion, right? Because even giving them 500 mils will help to rehydrate them, and then you might be able to then find an IV. So before you even start trying IV, let's get them hydrated. So think about hypodermoclysis. Again, we're going back to hypodermoclysis was used very frequently when I first started in nursing, and it's kind of gone by the wayside. And now it's made a comeback, and it's made a comeback because it is safe, it's simple, it's very patient-centered, it's atraumatic. It's a small needle that goes in the subcutaneous space. You can give, if you have 2 sites, you can give up to 3 liters of fluid in a 24-hour period. So it's a really good option to consider. And so in this scenario, that's what I would be advocating for. Let's do some hypodermoclysis. If we're really concerned about sepsis, can we give an IM injection, 1 dose of an IM injection to at least get them started on their antibiotic? Will help to rehydrate, we'll get the IV in, and then we can start. Or can we do an IM injection and then move to oral? There's always alternatives because we're so familiar with and used to having the IV, because it is ubiquitous to, especially in the hospital setting. Let's think about other alternatives that will be still act in the best interest of the patient, provide them with the right medication at the right time, but maybe in a different way. There is research that confirms, or we should say that's non-inferiority, that IV antibiotics and oral antibiotics are basically you have the same effect. So if the person can take something, that's always in consideration. The other thing is, can you switch? We talked about changing the times and dosage. So can we move from an intermittent infusion to a once daily gravity infusion? So that way you don't have to rely on the pump. You can give it by gravity once a day. The other option that's available that we're starting to see more and more in home care is infusers. So this is an example. Some people call them, sorry, you don't want to see my bedroom, but this is an infuser. And so this is one. We also have one that's referred to as a baby bottle. So these are, you might know them better as an Intermate, and that's a brand name. But these infusers are being used in home care for antibiotic therapy, intermittent antibiotic therapy. You have the IV, it gets connected to the IV. Either the patients are taught to disconnect and reconnect. It's very slick. We don't require a pump because it replaces the pump. So that's another option that could be considered also in the hospital setting. And this is a really good option for long-term care because it's a lot easier to take this little ball here and put it maybe in inside, if they're holding a doll, you could put it inside the doll's blanket, you could put it in their pocket. You can hide this quite easily and they will be less likely to try to play with it or remove it. So those are some really good options to consider. All in all, it's better to be proactive than reactive. So we know that COVID-19 is going to go on for quite some time. And so plan ahead for pending storage, for pending shortages. So think about, we talked about the pumps, for a hospital setting, how do you reallocate? So again, this is where the regional so the region can be looking at what they have and how can they best allocate it. Think about gravity infusions, get people comfortable with it ahead of time. So you have training, your professional practice, your nurse educators can train the staff on using these, because for a number of younger nurses, they probably not have had to do that before. Talk to your pharmacist about starting to bring in infusers as an option for medication. These are used for anybody who works in the hospital and oncology. Most chemotherapy agents are being infused via an infuser for patients that go home. So there's lots of options. I am a fan of hypodermoclysis, in case you couldn't tell. So always think about that and looking at how you can adapt and bring that into part of your repertoire as soon as possible so that people are comfortable with it before it becomes an emergency. And always look at alternate routes. Does the patient need an IV? That's question number one. If they do, what other options can we prefer? I know people don't like to think about IM injections, but most of the antibiotics were given IM before we started using IV. So that's always an option for you. So hopefully, I hope I haven't gone too fast, but that's kind of like my overview. And Tanya, we have lots of room for questions, I think. And so hopefully I've generated a few.
Hi, Karen, it's Tanya. Yes, I've got a question here from someone on the chat line. It just maybe goes back a little bit to when you were speaking earlier. The difference between macro and micro GTTS, as well in the GTTS count. I hope I've said that right.
Yeah, it's drops. GTT. That's okay. Micro versus macro drops. On the package of your so your administration set package, where am I? Right here. Okay, so it will tell you the drops. So your standard flow rate, so this one has a big 10 right here, so that's your drops per minute. So the micro versus macro tubing is really the size of the tubing. This is, I don't know if you can see very well, but this is a macro tubing here. And I think I have, yes, hang on, bear with me for one moment. So it's not so much the tubing is about how much volume is required to fill the tubing. So this is your standard macro tubing, right? 10 drops per mil. And this is your micro tubing. And so it's this, so sorry, the drip rate is determined by this, not necessarily the size of the tubing. So just to be clear on that one. And so the micro versus macro is how much volume is in the tubing itself versus, and also for looking at hallways, it's how much room it's actually going to take. Will it fit under the door? So so just to reiterate, the drops per, well, the drop rate is determined by the brand of the tubing and the drip rate that's been established. So it's not necessarily micro versus macro. There might be some connection to that, but you would be looking at the package to tell you how to calculate based on what the drops have been by the company itself. So like as in this case, it's 10 drops per mil. I hope I answered that. Okay.
I don't know, for the person that submitted it, let us know if you need any additional clarity. Yeah. And everyone else, just please submit questions on the chat line. I don't know, Karen, is there anything else that you were talking about that you'd like to elaborate on a little further, especially as it relates to setting up in, if you're not necessarily using a per room setup where you're setting up the pumps outside the room, what if you're in a large open ward area, but you're still setting up the pumps at a distance from the patient in the bed? I mean, can you comment on how you would do that?
That's a really good question. I did forget to mention that. It's from a safety perspective, having the pumps in the hallway really only works for one patient per group of pumps. It would become it would be very difficult to try and maintain that and not be distracted. You might want to, you could put the pumps at the foot of the bed perchance if you have enough room. Otherwise, it is, you know, the ISMP, the ECRI, they're not recommending doing that. I know some people are. Again, probably what you might want to be doing is designate the zone that then is accompanied with these pumps. So as I've mentioned before, we use this red tape on the floor to help us identify a zone that was, you know, free of distraction. This is one that you might be able to use if you're in a ward where you're having, so I'm thinking for like multiple pumps, that would more likely be in a critical care unit. And in an open critical care unit, there is designated space where all of those pumps are for those patients. So not every ICU has individual patient rooms. And so having worked in those, that's what we did, is we had them designated for the patient. We used a labeling system for multiple medications. We would do double lines to separate one patient zone from another, just so that people would be aware that to try and stay within that, because it does, the more pumps you have, the more equipment you have, the greater the breach into the other patient's space if they don't have as much. So those are some of the practices that we use, and I'm sure some other critical care places use things differently. I've worked in ICUs where they were so tiny, and we literally had to crawl over IV poles to get to the patient. It was just crazy. So now most of them have lots of room, which is an option. The other option you can do to reduce that, if you have it available, is to use syringe pumps, because you can put multiple syringe pumps on one IV pole, which helps to reduce the actual volume or physical size of the pumps. So those are options. I think the other thing that I wanted to say as well is, when you are using pumps in the hallway, to be really clear on labeling every tubing that goes from the bag through the pump to the patient. As I'd mentioned, we had one of the things that we would use is we color-coded everything. We also color-coded the pump. The catheter. So if they had a multi-lumen, the blue was always for X, the yellow was always for X. And so we had that, and we had it posted at the head of every patient's bed and also at the foot of the bed, so everyone knew what color was to what. So like nitroglycerin infusions were red, dobutamine was green, so it just was a standard throughout the entire critical care units, all of them, so that whoever was working there would know what to do. So again, that standardization is really important to help to reduce the risk of error.
Thanks, Karen. Thank you. I've got another question that came in, actually several. I hope we can get through them before time.
Okay.
Can you clarify, Karen, a time for recommended changing of IV in terms of number of days? You'd mentioned 72 hours, and then you'd also mentioned up to 7 days. Can you just clarify?
That's for IV tubing. So for IV tubing, again, depending upon the organization, some change every 72 hours, some change every 96 hours. Most of the guidelines are saying to change every 96 or every 4 days. Again, when you're looking at pending shortages of administration sets, especially associated with your smart pumps or administration sets that are specific for a pump, there is research that you can that will support you going to a 7-day change time or a 7-day use time.
Karen, are you able to share that research or those?
Yes, absolutely. Mm-hmm. Yeah, we can send that out to people for sure.
Thank you. Another question that came in, not sure you can answer this, but I'll pose it. Says, not sure if you're able to comment on hydrochloroquine, azithromycin treatment for COVID-19.
I could comment on that, but it would be opinion, and I would prefer not.
Right. Right. No, exactly.
Good question. The jury's still out on that one. So I am keeping an eye on the research, but right now it's still mixed.
Right. Let's watch the research.
Yeah. Mm-hmm.
As information comes out, I'm sure it can be shared.
Yeah.
And then there was another question. What about butyrols?
Butyrols. I forgot. I haven't used those for so long. I completely forgot they're still around. Good idea. Yes, that's another option.
Yeah.
Yes. Yep. So those of you who don't know what a butyral is, it's you put, I'm going back in my memory. I think it holds up to 100 mils in a little container. So it attaches to the IV bag, and then you can then regulate the amount of, you fill it up, and then you can regulate the fluid from there. So if you're concerned with fluid overload, this helps to reduce the risk of the IV running away. Buretrols were, maybe they still are being used for pediatrics for sure, because simply because of that reason. Yeah, good one. Mm-hmm.
Is that a place to source it then? If you don't have it on your unit, you can hunt around the hospital for it, like?
Absolutely. Your materials management would know if you have that available for sure. Or you can call the PEDS unit. Yeah.
See. Okay, thank you.
Yeah.
Thank you. So we're almost at time. Any other questions? A very long one. What is the consensus on medication administration in the community setting? I'm being directed that I don't need the paper copy of the physician's orders to administer depot injections. I'm also told that paper charting for medication administration record is no longer an option. Technology is a barrier with internet access issues in remote rural areas. The electronic medication administration record is not implemented yet in my department. I'm told to just read the order on the ampule vial or injection box. And that's
okay. That's a really good question. It's a really good point. If the medication has come from the pharmacy, your pharmacy label will confirm the physician order, so you can use that. And that can be documented in your record. And so we, having worked in the community, we would run into situations where the doctor would say, okay, I want them to have heparin, and that's it. And we'd go, great, and the patient comes in with this box or fragment. And but the pharmacy label is specific. It is in concert with the physician order. The College of Nurses of Ontario have confirmed that the pharmacy label can substitute for a physician order. And so when we were working in clinics, we would ask the patient to bring the actual box with the pharmacy label each time that they came in, so that we could verify the physician order on the pharmacy label. So that's an option for you. I know that working in remote and rural areas that you don't have that internet, and if you don't have the pharmacy label, you need to have something that verifies, because that is part of our requirement as from the College of Nurses, that we verify the physician order each and every time before we give the medication. So I would be asking and advocating for an alternative in those cases where you don't have any data or internet access.
Okay, thank you, Karen. So we're almost at time. Okay. And Karen, thank you, Rosalie sent a thank you, great webinar. Thanks for your knowledge and time. Thank you.
Thank you.
Yeah, Karen, do you have any closing remarks before we sign off?
Yeah, okay, I can, sure, I do. I always have closing remarks, no, I'm just kidding. I think that, hopefully I've shown at times where we're challenged to do the right thing in a situation that's an emergency, it's really important that we fall back on what are the principles of safety. So think about as I mentioned earlier, anywhere from your 5 to 14 medication rights, and how do we best do that given the situation. COVID-19 it's an emergency, so we're outside of our normal. And so given that the parameters are looser, that it doesn't mean that we don't, that we dismiss or fluff off the safety requirements that are needed to reduce the risk of medication error. And so how can you best do that? This is where you have your pharmacists available, you have your quality risk people. They're going to rely on you, especially those that are actually what I call direct caregivers. They're relying on you to provide them with the information they need to make sound decisions. So it's things like, okay, so if we have barcoding and we have to have a double, how are we going to do that if, we have to have a double barcode scan, but we're trying not to increase our risk of exposure? How can we work around that to still provide a double check? So like some people are putting the patient's ID on the window. Some people are putting it on the pump so that we know it's, the patient. So those are things that, again, the principle is making sure we have 2 identifiers. How can we do that in a safe way? Managing personal health information protection, and at the same time reducing our risk. So again, it's using those principles to help guide the best practice.
Great, thanks, Karen. And to everyone, we have recorded the session. And we'll be sending that out as a link for you to review. And we've got some best practice guidelines that Karen is going to be forwarding to you through us. So you'll be getting a note again from Health Leadership and Learning. Look for us in your email box. Odette is projecting right now on your screens our contact information. So there is, you can reach Karen Laforet. There's her LinkedIn and her Twitter. And you can also contact us either through our email, hlln@yorku.ca, or you can reach out to us through our Facebook account or through our Twitter account. We want to thank you for spending the time with us during this hour. We really realize that your time is very valuable at the moment, and we're here to offer you knowledge or information that can be useful to you at this time. Reach out to us if there's any other topics you feel that we should be covering to support your clinical activities at this time. But again, thank you to you for doing what you're doing, and be safe, be well, and we wish you all the very best. Thank you so much to everyone. We're getting be safe notices as well through the chat line. Thank you all.
Thank you. Take care, everyone. Thanks for everything you do.